Hi, Neghae. How are you?
Hi, Monnie. How are you?
I'm well, thank you. I'm Monnie Wasse. I'm an interventional nephrologist in Chicago.
And I'm Neghae Mawla. I'm an interventional nephrologist out of Dallas. And welcome to the Nephro-Logic podcast.
So I am surprised that you're wanting to tape with me today because it's Saturday, May 16, and this is the breakout day where everybody's been queuing up for the last 3 days to get their Swatch AP collab watch. They're beautiful but they're still made out of materials that probably aren't going to last forever. But with the collaboration, I wore my old Swatch that I think I bought 30 years ago in the Schiphol airport when I had some extra money left over. The plastic is cracking. I can't actually fully close this sufficiently because it's just in bad shape. How about you? Do you have a Swatch?
That's funny because I was thinking the same thing. I was very much in Swatch mode. I have my Moon Swatch on today.
Okay.
And so this is one I've had for a few months now. But yes, I was looking at the lines and I realized I was not getting one of the APs today.
Well, apparently they sold out, or they didn't. The delivery didn't arrive at one of the Chicago suburbs today. Everybody really
Yep.
wants
I
one.
thought they'll come back. This is not a limited release. I'll just wait.
All right. Well, our topic today, I thought we would talk about one of the thorny topics that's in dialysis access, particularly around nephrologists making decisions about dialysis access, and it's how to manage the hypotensive patient. And I thought we would, since you and I both see these patients and do dialysis access planning in these patients, I thought I'd start us out by just asking this question. When you're evaluating a patient who tends to have a lot of interdialytic hypotension, what are some of the things that you think about in terms of provision of vascular access and the type of access they should have that's going to be long lasting?
So if blood pressure is really an issue, I think I really push for that fistula to try to get it first.
Why is that?
I think the fistula handles the hypotension better than the graft. And hero obviously becomes the challenges. And the biggest challenge in the hypotensive patient is when you're running low on access options.
It is.
Then what do you do? And I think having a fistula, especially a moderate flow fistula, 600, 800, 1,000, you can maintain well enough with a relatively low blood pressure to where it's not a problem. I think the hypotensive patients are the ones that are always risking of the thrombotic events, especially as the circuit gets longer across that PTFE segment.
So, what do you use in patients who may not have fistula options? Because many of these patients are hypotensive because they have a lot of autonomic burnout because they've been on dialysis for some time. They're the ones that have to have midodrine before their dialysis sessions. And, what I recall from studies is that midodrine gets you through a dialysis session, but I believe that there are at least 2 studies that show that midodrine does not reduce the episodes of thrombosis of AV access. So while we like to use it, and it's kind of the, Hail Mary that we use in a lot of patients who are hypotensive, what other options do patients have who might not have AV fistula options, but they're hypotensive? Their systolics are routinely in the 80s and 90s.
I mean, honestly, I think the thing we always forget is PD.
Yeah.
And that's really becoming the push, is to say, hey, have someone talked to you about PD? Have you considered PD? Can we switch you to PD? And I think that's really where, when we start considering blood pressure, that's where I start thinking is, have we not considered PD as an option?
I think that's really important. The other thing I consider is use of biologic grafts. So I think that those can be wonderful to employ in patients who are hypotensive, who don't have fistula options. So bovine carotid, bovine mesenteric, they wiggle, they have pulsatility. They're the next best thing to one's own autogenous access. And I think that those can be very helpful in patients who don't have AV fistula options, but who are likely to thrombose if they end up getting an AV graft.
I actually never thought about the biologicals as kind of an intermediate option.
Yet they work well, I think. I like those for patients that both have hypotension, but also people that are at risk of recurrent infection, where there is some data to support that they have less risk of infection than PTFE or standard grafts.
The artegraft is a biologic, isn't it?
Yeah.
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 That's the one that I've seen a lot of people here use.
We've talked about what type of access we should actually target in the patient. Our dream is always to get a fistula in them. Sometimes that's possible. Sometimes that isn't. If you can't, and you're stuck with an AV graft in a patient, what's your approach to pharmacologic therapies such as blood thinners, antiplatelet agents in these patients? Do you find those are helpful? And is there any data to support that in this particular patient population?
We use it anecdotally. It's the sure, why not? Sometimes I think it's a risk-free approach, but it's not, especially in some of our elderly patients. But Eliquis has gotten very, Plavix nobody's using for dialysis access. Aspirin, I
That's
don't
not
think.
true. That's not
Really?
true. There are a lot of people that use Plavix. There are a lot of people that use Plavix.
Nobody
Yeah.
here's using Plavix for dialysis access.
I'm in the Midwest in Chicago. Plavix is everywhere for vascular access.
Everybody throws Eliquis out now. That's where everybody's shifted to.
Yeah.
Coumadin has fallen out of favor. Anybody up there using Coumadin?
No. I mean, luckily, no, that's a difficult drug. People are transitioning to Eliquis, but some patients who may have an underlying thrombophilia, Jeff Lawson is a big proponent, vascular surgeon who has been at Duke for a long time, who also has a PhD in thrombotic disorders and is an expert on platelet dysfunction, really believes that there are a number of patients who just have these mysterious thrombotic events where there's no real anatomic problem. And you run them through the thrombophilia panel, anti-lupus and protein C, protein S deficiencies, and you just don't come up with anything. And he's a strong believer in the idea that we just haven't diagnosed some of these, or we haven't named some of these underlying thrombophilias in patients, but they may still have them. So it's worthwhile thinking about Eliquis, which is why I like Eliquis a lot, because the antiplatelet agents are not effective for those, whereas Eliquis is as an anticoagulant. But antiplatelet use, aspirin and Plavix, is very common where I am. And I think it just comes from this notion of the cardiovascular literature where people use it there and they just insert it into vascular access without having, I think, there's really very limited data. It's highly anecdotal. And it's more art than science, largely.
Correct. And I agree with that it's one of those things that was done. I mean, a lot of people here do it empirically. Like, yeah, let's just put you on Eliquis and you see what happens. I was happy to see that there was one poster we saw at ASN last year, the year before, that made it into KI, I think.
Yeah, it was
in
published.
2025. Eliquis actually did help after a thrombotic episode for the next 3 months. I think it was 3 months of Eliquis that was used. Is Jeff a proponent of just kind of this throwing Eliquis out there? Do you know? Have you talked to him about it?
I haven't talked to him about it. We're going to be seeing him at an upcoming meeting, I believe. And so that's a good question to ask him. I think he has very much the same approach as many of us do, which is that once you've eliminated anatomic issues and anatomic reasons for patients to clot, you've addressed issues of dry weight at the dialysis unit and tuned up somebody's target weight, taken them off of all of their blood pressure medications and so on. I think at that point, you really just get, there's only one or two other options, and that is you either switch them to PD if they're a candidate for that, switch them to a tunneled line, obviously, and some of our patients have to have that. But I think that, again, his belief, which after having done this for a couple of decades now, I agree that we just haven't named some of the thrombophilias. And so if somebody's behaving as though they have one and just clotting for no really good reason, and there's no downside, they don't have, recurrent GI bleeding or persistent anemia that's not treatable with, IV iron and EPO, that it's worth doing a trial and seeing how things go. And that's the approach I take.
Okay. Anatomically, if it was an upper arm graft, brachial artery to axillary vein, do you think proximalizing it to axillary artery changes because you're hooked into a larger artery? Is it give you better outcomes? Or now that you've got a longer PTFE segment, does that neutralize the effect?
I get that sense. I don't go for proximalization, and I don't ask my surgeon to proximalize unless the patient is actually having some ischemia in the distal extremity. I think that's what it's good for, and mitigating issues around the potential of steel. But the idea that you would hook up an access to the axillary artery, for example, as the inflow, means that you have to, one, you're putting in a graft for the most part, unless they're a brachial bacillic candidate. But assuming that it's a graft, because you have to have enough length on that to actually have sufficient cannulation segment, I think you're just fighting yourself. And I think that I think they kind of cancel each other out. So
I kind of feel the same way too.
Yeah, not one of my go-to moves if I am dealing with somebody who's hypotensive. And I think that now that the new KDOQI guidelines have come out, which I know we spent a lot of time talking about at our dialysis access meetings, this notion of really individualizing, we still have a lot of pressure on the dialysis unit as nephrologists to get catheters out, but they are the appropriate thing sometimes for patients. We all have those patients that The surgeon puts in an access and it's literally clotting every 4 to 6 weeks because the patient's hypotensive. And none of us would want to go through that. As long as the patient doesn't have a lot of risk factors in terms of infection, and they're not a peritoneal dialysis candidate, I sometimes will just have a discussion with the surgeon and the patient, and we will transition to a tunnel catheter because they don't want to spend their days in a dialysis access center getting a declot again. So
Again, over and over again.
Yeah.
Last episode we talked about dialysis and kind of the dialysis centers. I do not round at the dialysis centers anymore, but remind me, and the penalty that the dialysis centers and the LDOs get, it's not for someone who's been declared a permanent catheter, correct? As far as the metrics, as far as their internal metrics,
Yeah.
right? If you declare someone a permanent catheter patient, then they are excluded from the perm cath ratios and metrics and all of that.
That's my understanding. Most of my patients don't have catheters, but what is tracked with the USRDS data, what the patient starts with, and then what they have at 90 days. And so what we work towards in general in the United States, 82% or so of patients initiate dialysis with a catheter. And then about 60% of those patients still have a catheter at 90 days. They may have something else in their arm that's maturing, but they still have the catheter in. And then they typically the dialysis units will track this. What the financial penalty is for that now, I believe there is still one, but I think that once you've declared that patient as a catheter consigned patient and there's rationale behind that, I don't believe that there's an ongoing financial penalty as a result of that. So our audience, when they hear this, will correct us if I'm wrong. Yeah.
I think it's like you said, we shifted from fistula first to catheter last, but catheter okay is still an option.
It is, especially for patients like that. I mean, I relate to that. I wouldn't want to be spending my days seeing me in a dialysis access situation on a non-dialysis day. It's just, it's too much. So, but this is a conundrum in these patients. And I think that if you're on dialysis for several years, you are at risk of having chronic hypotension. That's who we tend to see who has it. And so another emphasis is trying to move forward with transplant. Obviously, that's the question that I always ask when I see the patients. Are you on the transplant list? Because again, that informs me about how I'm going to approach the patient, if I'm going to stent them, if I'm not, if they need a revision sooner than later, that kind of thing. I don't know. In your area, do you have transplant denials because of these patients that have systolic blood pressures of 80 and 90?
No, not for that reason. Other reasons, yes, but not for hypotension.
I have heard that in my area, is that some patients are turned down because they have hypotension. And there is actually data to support the idea that when you do, in fact, transplant these patients, their blood pressure recovers. So there's something about that milieu of, having a sufficient kidney function that lends itself to autonomic re-regulation that is not present when these patients have this burnout. But that is a reason why some transplant centers will deny a patient, which I just find really troubling, honestly.
Interesting. Now
Yeah.
that I did not know.
Yeah. So one other thing I think that's useful, how easy is it for you to transition, to talk your patients in to converting to peritoneal dialysis for this reason in particular?
Honestly, most of them, the challenge is not the responsibilities of doing PD. Most of them are willing to step up to that responsibility. It's the 3, 4, potentially 6 weeks of training that becomes a limitation. It is storage and where am I going to keep all my supplies? It becomes a challenge. And it's pets and how do I keep my animals out of it? And I think those are honestly the biggest hindrance to a lot of people transitioning to PD. I've actually found more people are willing to try home hemo before they switch to PD.
Oh, interesting. That's interesting. So I still see dialysis patients and peritoneal dialysis patients, and I find it difficult to transition patients from hemo to PD. I think that and oftentimes if a patient starts on hemo and then they get immediately switched to PD, they really appreciate PD because they didn't like having to show up to a dialysis unit and kind of be at the mercy of a dialysis schedule. And so the freedom of doing PD at home. But you're right, for those that have gotten acclimated to hemodialysis for long periods of time, it can make it very difficult to have that conversation to convince people that their blood pressure just really isn't supported. Their recurrent thrombosis of their access is such a problem that we have this alternate option for them. And many people can be very resistant to that notion.
Yeah.
Yeah.
Heroes, what's your cutoff for blood pressure for hero candidacy?
So my cutoff is pre-dialysis systolic blood pressure of 110-ish. 110, 115. we have these multidisciplinary conferences where I am, and we have conversations about the baseline blood pressure when the patient shows up for dialysis is 110, 115. But most importantly, what does it actually fall to during dialysis? So that's the information I always seek, which is what was the lowest blood pressure in this patient? If it's dipping down into the 85, 90 systolic range, I don't think that typically that patient is a good candidate for a hero graft because
Yeah.
they're just going to have problems.
They're just going to have problems. And as far as a procedural thrombectomy, they're the easiest ones to do,
They are.
but it's just a recurrent thing over and over and over again.
Yeah.
And it usually happens that the story is I got my treatment, I went home and I was clotted that night after the treatment. And it is, I think it's that blood pressure. And patients that are looking or I'm considering a hero access for, I always look at the blood pressure trends and logs from the dialysis centers. They're good about sending me their treatment sheets, at least, even if it's not necessarily the most recent one, but something within the last couple of weeks. And that becomes very much a factor that what is your post-treatment blood pressure for me, not your pre.
Yeah. So what's your cutoff?
If you're below 100 post is the one where I say, I don't know that you're going to sustain a hero.
Okay.
And it kind of boils down to conversations about, do we try it and see what happens? Do we not try it? Do we go another route? But it becomes one of those things that I just say, hey, if your blood pressure is not 100 at the end of the treatment, then we might run into the problems with this staying open over and over again.
Yeah, I think that's reasonable. There's nothing worse than having patients go through all of that only to then be in your dialysis unit for a declot. As simple as they are, it's not what they should have to go through. Just isn't.
Right.
So it's not the right decision.
One thing I learned over the last couple of years as I was screening for the percutaneous fistula patients, but also more importantly, those that were not candidates, because most of them are actually not candidates, and sending them off is there are so many other factors and variables to consider other than artery size, vein size,
Yes,
right?
absolutely.
But it's so easy to fall into that trap of look at this artery, look at this vein, look at these numbers. If your numbers are good, go forward.
Yeah.
And that doesn't always, and especially considering blood pressure into that factor, I think it's
Yeah.
a big thing.
Yeah, I mean, this is more complicated than I think people give it credit for. It's disrupted anatomy and it has so many hemodynamic elements to it that can have such a huge impact. You can put in a perfect access and it's still going to go down because the patients may not be able to support it. Which brings me to my next question. What's your cut point for ejection fraction? Because obviously that is something that portends the success of an access staying open also.
I will be honest, I have never looked at it and considered it.
Really?
So, yeah, really. I don't get echoes or look for them in my access consideration. So tell me why I should.
Well, I don't pre-echo people before they get an access, but most of our patients have one, at least in the previous 6 months or so. So I usually check it, but not everybody who has a low EF has hypotension, as you know. But those patients tend to be a lot more labile during dialysis because when you're having volume shifts of 2 to 3 kilos or so during the week, and that's getting pulled off during dialysis, I think that those patients have the most significant change in their blood pressure during dialysis, but also they are the ones that are at risk of having distal ischemia because if they have underlying diabetes and hypertension, a lot of them have poor compliant vessels, and it's just a setup for lack of successful access. So for me, I look at the heart failure scale, and oftentimes I will look at patients and not recommend for patients who have New York heart failure 4 and 5. Those tend to be patients that I think have a lot of challenges with regard to keeping their grafts open. Those are patients that I would attempt or I recommend to the surgeon, let's give a fistula a try. But there's a lot of explanation that goes to the patient about this may not be successful, or you may be at risk of having some distal ischemia in your hand because you have pretty significant heart failure. And some of that is going to be stolen by having this parallel circuit that's in your arm, particularly when you're dialyzing. It is something that actually I pay attention to. I wouldn't put an AV access in a patient who had an EF of 15. I just wouldn't. I think that those are patients that should have a catheter or do peritoneal dialysis. So it's just one added thing if I have it. And you can usually tell because when you're checking pulses on these patients, you ask yourself, why is this weak? Is it because the vessel is diseased or is it because their pump is actually pretty weak? And that's when I go looking around for the echo report.
Something else to add to the list, right? And it goes back to access planning about what else is there besides just vessel sizes?
Yes, absolutely. I mean, that's where all your flow begins. The origin source of your flow is at the heart. And so if your ejection fraction is poor, or the patient has a big floppy heart, or they've got bad valvular disease, those can all play a role in how successful your access is.
What else do you want to teach people about blood pressure?
Well, one really obvious one is I had a patient about 2 weeks ago who had very few options. She was likely going to be set up for a hero, and I did a vessel mapping on her bilaterally, and I always ask the question, what's your blood pressure like? And while she was on my table, her systolic blood pressure was in the low 130s, which I would consider completely fine for a hero graft. But she told me, she says, it's low on dialysis. And I said, well, how low? And she said, oh, it goes into the 105, 100. I said, do you get dizzy or symptomatic? And she's like, yes. So I asked the obvious question, are you on blood pressure medication? And of course, she is on 3 agents, and she was taking midodrine for dialysis, which makes zero
Beautiful.
sense. So those are some questions to inquire about when you see a patient. It does not always make sense what ends up happening at the dialysis unit. Sometimes, in fact, they are on midodrine to boost their blood pressure while they are on antihypertensives to treat their blood pressure. I had to make a call to the nephrologist and have a chat about trying to wean her off of her blood pressure medications so that we could move forward with an access that worked in her.
A lot of these things are lost in translation.
Yeah.
The midodrine that's supposed to be dialysis treatment only days becomes an everyday thing somehow. Blood pressure medicines that were weaned off before somehow get put back on again. And I've seen that both in my own patients and other patients, that medication lists are not necessarily always up to date. And I typically will try to ask patients to just bring all their bottles and let's take a look based off what you're taking, not what a piece of paper shows.
Sure. You're right. That's the source of truth oftentimes. All right. Well, other aspects of this conversation to talk about?
I think it raises a lot of questions for other things to talk about.
Okay, good.
Which is where I enjoy talking to you and going with this, because as we start talking about one thing, then it brings up other ideas to discuss and bring up.
Okay. All right. Well, we'll wrap this one up today. Thank you. And we'll see you next time.
Until next time. Thank you. Bye.
Bye.